Just a quick check. Secretariat, can you just confirm if you are able to hear me clearly and am I clearly visible?
Yes, sir. I'm able to hear you, sir. Yeah.
Okay, thank you so much for confirming. Really appreciate. I can see Dr. Rajiv Jain sir is already there. Very good evening, sir. Can see you very well. You are on mute, sir. I'm perfectly fine.
Oh, good evening, Dr. Pavan.
Good evening, sir. And I did lip reading. You said, how are you? And I said, I'm fine.
Wonderful.
Yes, sir. So we will just take a couple of minutes for housekeeping stuff, and then we'll announce this open, right, sir? With
Yeah,
audio.
that's fine.
Yes, couple of more minutes, and in the meantime, more people will be joining in. So taking 2 minutes. Yes, sir. Thank you, sir.
I think we can go ahead. Let's begin so that we do not lose time. Ultimately, the people who have arrived, it's injustice to them.
Yes, it's absolutely right, sir. It's just that I
honor the revered people who have joined on time.
Yes, absolutely. We have to honor them. I'm just trying to check all the housekeeping stuff and just checking with the secretariat if everything is in place. And that's why I needed 1 minute. Right, sir, right. Just a second, sir. Well, very good evening, Dr. Chaudhary. I can very well see you. Thank you so much for joining in. It's a cold Saturday evening of Delhi. Looking at you. Yes.
Snowfall in Srinagar,
Yes, sir, yes. Probably that's the reason, yeah.
So there's already snowfall in areas of Himachal and the Uttarakhand already.
Yes.
Srinagar is late by 10 days now.
I'm feeling cold. Dr. Chaudhary.
Chilly winds in Delhi.
This time I'm totally packed. Don't worry.
Yes.
That's
Yes.
Only there's only young person who is only jacket and the shirt. And
my room is warm. Yeah, I prepared the room warm for this meeting. Okay, that's I think I'll just, and we can see that Dr. Siva has also joined. Very good evening, Dr. Siva. Absolute pleasure. Thank you so much. And Dr. Behera is also here today. Very good evening, Dr. Behera. You can
good evening.
Yes, good evening.
How are you all? Good evening, sir. Jain, sir.
Good evening. How are you, Dr. Behera?
Fine, sir. Thank you.
Okay. Well, very. Well, sir, I think we are all set to start our 83rd webinar as a continued engagement. Very good evening to everyone and a very warm welcome on behalf of AUSG, Delhi branch of Indian Association of Occupational Health. A very warm welcome on Saturday evening. Absolute pleasure to have you all on this DG Connect webinar platform that we have been continuously running since 83 weeks. That corresponds to, it will be close to 2 years very soon. And all the contributions that have been made by learned speakers, key office bearers, authorities is very well acknowledged. And we are very thankful for this continued engagement and endeavor. During COVID times as well, this was a continued engagement and we were able to maintain the continuity. Many thanks to the Secretariat for all the efforts that Secretariat has put in behind this. I am Dr. Pavan K. Gupta, member executive committee of AUHD and the secretary AUH Haryana branch. We gratitude and thanks to all of you once again. And as I mentioned, it's a matter of great privilege that I get this opportunity to host this so continued and long-running platform, host this webinar. I'm really thankful to the office bearers and the authorities for giving me the opportunity, and also to the AUHD. Sincere thanks to executive body. I have already mentioned about the effort that Secretariat has been putting in all this time for maintaining the continuity and the way we have been able to engage with the speakers, and all thanks to the learned speakers who have joined in on the platform and contributed. So we have two learned speakers as a routine process, that the way we usually take it ahead. And today it will be our very own Dr. Rajiv Kumar Jain sir, a Senior Vice President of AUHD, who will be taking the deliberation first, and followed by our speaker, Dr. Peush Bajpai, who will be deliberating on the subject matter, which I'll be sharing in a while. Quickly touching upon the timelines, we'll be having half an hour slot for the speaker slot, in which we'll be having 20-25 minutes of deliberation, presentation, and 5 to 10 minutes of question and answer. And this way we'll try to wrap up the entire event by 8 p.m. Please keep posting in your questions, either in the Q&A box or in the chat box, or you can directly send, if you have my number, on WhatsApp, or you can send it to the Secretariat, or through whichever means you want to send in your questions. Please, you're most welcome. We will be taking them in the order of their appearance, and also after the session, definitely we'll be taking up the questions live as well. We encourage to have a thorough reciprocative webinar discussion, and this is how it has been, and we have been enlightened by many facts and figures during this course of time. So with that, without taking any further minute, I would like to introduce our first learned speaker of the evening today, Dr. Rajiv Kumar Jain sir. Dr. Rajiv Kumar Jain is a senior consultant, health, Indian Railways, New Delhi. 40 years of experience in health and hospital administration. Fellow Award of Indian Public Health Association. Fellow Award of Association of Environmental and Occupational Health, Delhi. Published, presented more than 145 scientific papers in national, international conferences and journals, and also books. Fellowships, scholarships by World Health Organization, National Institute of Health, USA, Canadian Society for International Health, International Clinical Epidemiology Network, and International Society for Priorities in Healthcare. Dr. Jain deliberates and shares his views and thoughts on this evolving situation related to COVID. He has been a continued contributor, and he has enlightened many of us on the facts and figure, and he has kept us updated on the evolving situation. Today also we are going to hear more from him, and definitely about the Omicron as well. We look forward to your deliberation, sir. With that, I give this e-platform to you, sir, for further proceeding. Thank you very much, Dr. Rajiv Jain, sir.
Thank you, Dr. Pawan.
Thank you very much, sir.
Today being Saturday evening, and here we are again with the 48th episode of COVID-19 epidemiological updates. When we say COVID-19, fine, but Epid updates means epidemiological updates. And what is epidemiology? We take a review of the spread in time and geographical spread of COVID-19 pandemic, as we have been doing for last now around 2 years. And this is the 48 episodes. And with the end of this year, we should be touching the 50th episode of COVID-19 Epid updates. Epidemiology teaches a lot of things for your day-to-day living and for your life and livelihood as well. This pandemic has taught how important the epidemiology is as a subject. So let's begin with Omicron. How can we not try to start our deliberations on Omicron. I would like to play a video which will talk about Omicron salient features. Let's look at the video and then review the data on the ground.
We're doing an update on Omicron in Science in 5 today. Hello, I'm Vismita Gupta-Smith, and we're talking to Dr. Maria Van Kerkhove. Is Omicron more severe? Is it more transmissible? And how can you protect yourself? Welcome, Maria. Maria, what do we know so far about the transmissibility of Omicron?
So thanks, Vismita, for having me. We're learning a lot about the Omicron variant every day. In terms of transmissibility, we are seeing a really increased growth rate of Omicron over other variants of concern. These are some of the sharpest increases that we've seen to date. We do know that it has what we call a growth advantage over Delta. And what this means is that we're seeing a large increase in cases where Omicron is detected. At the time of filming this, Omicron has been detected in more than 77 countries, but it's likely that it's present in other countries as well. The big question right now is how will Omicron compete with other variants that are circulating in populations? For example, will Omicron outcompete Delta or not? It's still a little bit early for us to have a full understanding, but what we can say is that some of the mutations that are identified in Omicron will provide it a growth advantage, will allow it to be more transmissible. So this is a concern that we have. And as we know, more cases, if there's more increased transmissibility, which is what we are seeing, we'll have more cases. More cases mean more hospitalizations, and more hospitalizations can put healthcare systems that are already overburdened into a state where people will not get the appropriate care that they need.
Maria, does Omicron cause more severe disease? And what are the symptoms we are seeing so far?
We're still learning about severity as well. We do know that people with Omicron can have the full spectrum of disease. Everything from asymptomatic infection, mild infection, people needing hospitalization, and people have died from Omicron. We do have initial reports that suggest that Omicron is less severe compared to Delta. However, if we have more cases mean more hospitalizations. And if a healthcare system is overburdened, people will die because they won't get the appropriate care that they need. So it's early to tell whether or not Omicron is more or less severe, but we do have some initial reports that it is less severe. Now, don't be fooled. Even if we have a virus that causes less severe disease, this virus can affect vulnerable populations. And we know people with underlying conditions, people of advanced age, if they are infected with any variant of SARS-CoV-2, including Omicron, they are at an increased risk of developing severe disease. So it is really critical that even if we do see more mild disease, we still do everything that we can to reduce transmission in all populations, people who are vaccinated as well as people who are not vaccinated. In terms of disease presentation, there are many studies that are underway that are looking at this in people who are infected with Omicron compared to other variants. We have not seen a change in the disease profile. For example, we haven't seen a change in the symptoms that people present with Omicron compared to Delta. So you won't be able to tell the difference. So the best thing for you to do is to keep yourself safe. Get vaccinated when you can and make sure that you take steps to reduce your exposure to this virus.
Maria, what can people do to protect themselves against Omicron? And what about the current batch of vaccines?
So there's many things that people can do to keep themselves safe. First of all, is get vaccinated. Now, there are many studies that are underway that are looking at vaccine effectiveness against Omicron. And these studies are currently underway. We don't have that complete picture yet. But what we do know is that it is better to be vaccinated than not. And what is really critical in all countries is that those people who are at risk, those who are over the age of 60, those who have underlying conditions, receive their vaccines and making sure they get their first and second doses. Really, really critical that everybody get vaccinated when it's their turn. And at the same time, while we increase vaccination coverage among those who are most at risk in all countries, we also have to take steps to drive transmission down everywhere. And this is using simple measures. Physical distancing, wearing of a well-fitted mask with clean hands, avoiding crowds, improving ventilation where we live, where we work, where we study. The biggest factor right now is making sure you reduce your exposure to the virus, no matter what variant is circulating. Delta variant is dominant worldwide. That also needs to be brought under control. And everything that we do right now for Delta will benefit Omicron no matter how it unfolds, no matter what we learn about it. So do your best to keep yourself safe, get vaccinated when you can, and make sure that you reduce your exposure to this virus where you live.
Thank you, Maria. That was an update on the Omicron variant. Remember that as more information comes in, we will make it available to you on our channels. Until next time then, stay safe, stay healthy, and stick with science.
So you've seen how complex the disease is evolving, and the pandemic is still there. Let's go and see the data. Let's have the first slide, please. Yes. First, the good news. Nearly 97% in Delhi have got one jab. 210,000 jabs were given on September 20. And now on Wednesday, we had 106,000 total doses, 2 crore 45 lakh 4,000. And Delhi's population is 1 crore 48 lakh 98,000. 66%, 66.6% fully vaccinated and 30% partially vaccinated. And 3.4% is unvaccinated. And that's the danger. Let's have the next slide, please. United States this week surpassed 8 lakh pandemic deaths. The United States, the nation hardest hit by the pandemic, is the first nation in the world to have seen more than 8 lakh deaths, a figure greater than the entire population of several states there. 4 waves, different stories. 8 lakh 3,043 deaths due to COVID-19 across the United States. Close to 4 lakh 50,000 of these deaths have occurred in 2021, despite vaccines being first authorized in December 2020 and being widely available in the country by the first half of 2021. Going by the deaths, the third wave, which ravaged the US starting October 2020 through early 2021, was the most brutal, even though infections rose much higher in the fourth, that is the Delta wave. Daily deaths never surpassed the highs of the third wave, largely due to widespread vaccine coverage this year. However, even during this fourth wave, the rise in deaths was significant, with the country's south particularly hit due as they were low vaccine coverage areas. If you look at the map of US, America's worst hits regions, in absolute numbers, there is a vast variance across regions within the United States. More than 1 in every 4, that is 26.5% of all COVID deaths reported across the United States can be traced to just 3 states: California, 75,428 deaths, Texas, 74,707 deaths, and Florida, 62,073 deaths. These are followed by New York, 58,287 COVID fatalities, and Pennsylvania, 34,731 deaths to make the top 5. But these numbers may not accurately represent the regions that have been worst hit. For this, the population must be factored in. The South has the highest concentration of fatalities. Mississippi leads with 3,474 deaths per million population. The numbers from Mississippi are 5 times that of Vermont. This means that a Mississippi resident is 5 times more likely to die from COVID than someone from Vermont. And you are seeing the 10 states with least deaths on the left side and 10 states with most deaths on the right side. And you can see how in September 2021, white flags were placed near the Washington Monument to remember the Americans who have died due to COVID-19. And the President of the United States says, as we mark the tragic milestone of 8 lakh American deaths due to COVID-19, we remember each person and the lives they lived, and we pray for the loved ones left behind. As we head into the winter and confront a new variant, we must resolve to keep fighting this virus together. And the same goes for India as well. Let's see the next slide. This is the reality of India, tracking the new variant. India's Omicron count touched 113 with 26 fresh cases of the new variant on Friday, even as a large proportion of those have recovered. A look at where these cases are. Chandigarh, 1 case. And Delhi, 22 cases. Rajasthan, 17 cases. Gujarat, 7 cases. West Bengal, 1 case. Maharashtra, number 1, 40 cases. Telangana, 8 cases. Karnataka, 8 cases. Andhra Pradesh, 1 case. Tamil Nadu, 1 case. And Kerala, 7 cases. 113 Omicron cases detected across India. On boosters, responding to a query on why India has not started booster shots, officials said that since there is no resource constraint regarding vaccines right now, epidemiology and scientific discourse will lead to a decision. This time around, our vaccine resources are in good condition. What we are doing concurrently is engaging with our scientific community to look at the issue of booster doses. We have very competent teams examining this. This is what Dr. V.K. Paul, member Health Niti Aayog, said yesterday in the press conference. Next slide, please. Let's examine to understand the global Omicron threat. On Wednesday, the WHO said that preliminary evidence appears to indicate that vaccines may be less effective against infection and transmission linked to the Omicron variant of SARS-CoV-2, which also carries a higher risk of reinfection. According to data compiled by GSAID, a global science initiative that provides open access to genomic data of influenza virus, 60 countries have so far submitted to it sequencing data that shows the presence of this highly mutated variant on their shores. With its ability to evade vaccines and higher transmissibility, the new variant has sparked concerns that it could drag the fight against the pandemic back several months. Let's see the 3 slides to make us understand about the global pandemic of Omicron. The Omicron global spread is the first fact is of the 60 countries that have confirmed Omicron infections to GSAID. The United Kingdom has the largest share with 4,120 confirmed sequences of the variant till December 13, the latest date for which this information is available. It is followed by South Africa with 1,000 samples, the United States with 321 samples, Denmark with 216, and Switzerland with 125. A better picture is provided by looking at the share of Omicron in all cases in these countries in this period. South Africa, unsurprisingly, with 90.1% of all infections being Omicron, features among the top, closely behind Mozambique, where the highly mutated variant constituted 94.4% of all samples sequenced. To be sure, the Delta variant still easily remains the world's most dominant variant, accounting for 97.9% of the nearly 3.1 million genome sequences uploaded in the 4 weeks ending December 13 to GSAID. But the real case of worry is that despite Omicron barely being flagged in even half GSAID's 60-day sample period, it has already outstripped the combined proportion of the alpha, beta, and gamma variants. A total of 6,700 samples, about 2% were Omicron, and other 3 variants of concern together numbered 22. Less than 0.01% each in GSAID's database. A week ago, Delta's share was 99.2%, while Omicron's share was 0.4% in the same database. So you're seeing a sharp increase. Next slide, please. The regions where the new variant is taking hold are not faring well. South Africa, the United Kingdom, Norway, and South Korea. A key characteristic of Omicron that has been observed is that it can lead to a massive spike in new cases. For instance, in South Africa, on average, there have been 22,852 new COVID-19 cases every day in the past week, far surpassing the previous week peak of 19,766 cases a day in the first week of July this year. South Africa, however, is far from being the only that has seen a record spike at the same time that Omicron infections have seen a spike. On Wednesday, the United Kingdom recorded 78,610 new COVID-19 cases, the highest in a single day since the start of the pandemic. This has pushed the 7-day average of daily infections to 57,417, just below the peak of 59,508 touched on January 8. Similar peaks can be seen even in smaller countries such as Norway and South Korea, where the share of Omicron cases in the overall new infection tally has been rising in recent days. In each of these countries, the 7-day average of daily infections is currently at the highest ever, according to data gathered by our world in data. In Norway, there has been an increase of 4,925 new cases a day in the past week, while in South Korea, this number is 6,790. The corresponding charts also show that the share of Omicron cases have been increasing at the same time in these countries. You are seeing the red one, if you see in the graph inside the box, the red one is Omicron cases in each country. How it is now as a proportion to other variants, the Omicron variant is now dominating, as you can see in South Africa as well as in South Korea. Next slide, please. Omicron appears to be single-handedly capable of pushing new waves. To truly understand the impact that Omicron can have on the outbreak in a region, it is crucial to look at how these infections are changing the outlook of the COVID wave. Very few countries or even localized regions consistently release data on the spread of particular variant. This exercise is generally done so by extrapolating genome sequencing data on the overall case turnout. This system is utilized by agencies such as the US Centers for Disease Control and Prevention to determine a prevalence of a variant. On Wednesday, it estimated that 2.9% of the new COVID cases emerging in America were Omicron. However, one advantage that Omicron's heavily mutated nature offers is that in widely used RT-PCR tests, one of the 3 target genes is not detected, called S gene dropout. And this can therefore be used as a marker for this variant. While sequencing is awaited, using this approach, some regions have been tracking this variant at near real time, offering early views on how prevalent it is. In London, the prevalence of Omicron cases, that is those with S gene dropout, has been steadily rising. In the past week, 38.4% of all infections in the British capital have been Omicron cases. But that is even more alarming is that on daily level, this proportion is rising fast. On December 12, that is latest data for which data is available, 1,669 of the city's 2,779 cases were Omicron, that is 60.1%, according to data released by the UK Health Security Agency. Similarly, this proportion is also rising in Denmark, the only other major region which is currently publicly releasing S gene dropout data. In just 10 days between December 1 and December 11, daily Omicron proportion has gone from 1.6% to 15.6%, the data shows. In both these regions, a worrying trend is that Omicron appears to be the cause of the spike in new infections, as the new cases of the other variants appear to be stagnant. And that is what the graph is showing, London and Denmark. Next slide, please. Now we come to India. India lives in its districts. This data is from for the period 11 December to 17 December. There are 5 districts in India which have been showing more than 10% test positivity rate during this week. And these are one in Arunachal Pradesh, that is Dibang Valley, 10%. Mizoram has 3 districts, Sachib, Khazal, and Mamit, 15.7%, 14.6%, and 12.46%. And Nagaland has Zunebeto with 10% positivity rate. So 5 with more than 10% positivity. And next slide, you will see between 5% and 10% positivity rate. Let's see how many districts are there. Next slide. These are 21. So in India, there are 26 districts still showing more than 5% positivity rate. That means infection is actively spreading in these districts. In Arunachal, Namsai, Kerala has 10 districts. Thiruvananthapuram, Kottayam, Kozhikode, Idukki, Kannur, Ernakulam, Wayanad, Kollam, and Pathamthita. Manipur has Imphal West. Mizoram has Champhai, Nanthal, Longchai, Aizawl, Lungle, Saitual, Saiha. And Rajasthan has Bundi. Sikkim has South District, and West Bengal has Kolkata. So these are the districts in India, 21 districts which have been showing weekly district-wise positive rates of more than 5% and less than 10%. Really alarming. 26 districts in India showing more than 5% positivity rate during the past week. Next slide, please. This is Southeast Asia region for the week. The declining trend in reported new weekly cases and deaths continued this week in Southeast Asia region. Over 98,000 new cases and over 2,600 new deaths were reported, amounting to a 10% and 50% decrease respectively as compared with the previous week. Only 2 countries reported an increase in weekly cases. First is Bangladesh from 1659 to 1882, a 13% increase, and Bhutan from 1 to 8, a 700% increase. The highest number of new cases were reported from India, 57,255 new cases, 4.1 new cases per 1 lakh, a 6% decrease. Thailand, 27,405 new cases, 39.3 new cases per lakh, a 20% decrease. And Sri Lanka, 5,220 new cases, 24.4 new cases per lakh, and similar to the number reported in the previous week. The highest numbers of new deaths were reported from India, that is 2,108 new deaths, less than 1 new death per lakh, and 56% decrease. Thailand, 227 new deaths with less than 1 new death per lakh, and similar to the number reported in the previous week. And Sri Lanka, 153 new deaths, less than 1 new death per lakh, similar to the number reported in the previous week. And you're seeing the graph of the pandemic from the entire period, and it's going down, both the deaths and the cases. Next slide, please. This is the globally, the graph you're seeing, different regions of the WHO, and dominated by Europe, the green one. Globally, the weekly incidence of both cases and deaths declined during the past week, with decreases of 5% and 10% respectively, as compared with the previous week. Nonetheless, this still corresponds to over 4 million new confirmed cases and just over 47,000 new deaths. As of 12 December, nearly 269 million confirmed cases and nearly 5.3 million deaths have been reported globally. The African region reported the largest increase in new cases last week, 111% increase, followed by and the Western Pacific region, which reported an increase of 7%. The region of the Americas and Southeast Asia region both reported decreases of 10%, and the European region reported a 7% decrease. The number of new weekly cases reported by the Eastern Mediterranean region was similar to the numbers reported in the previous week. New weekly deaths decreased by 50% in Southeast Asia region due to an artificial increase in deaths from batch reporting in the previous week, and 14% in the region of the Americas, while the number of weekly deaths in all other regions remained similar to those reported in the previous week. Next slide, please. This is what is the graph from week-on-week basis. Next slide, please. This is a summary of phenotypic impact of variants of concern, and you look at the extreme right, the Omicron. Transmissibility, no direct evidence for increased transmissibility. Disease severity, not yet known. Clinical outcome data under review. Risk of reinfection, preliminary evidence suggests a possible increased risk of reinfection. Impacts on diagnostics, PCR continues to detect Omicron. Impact on antigen rapid diagnostic test is under investigation. Next slide. This is the summary of all the primary series of vaccine performance against variants of concern. And this, you see Omicron, the very little data that is available. Neutralization, you're finding, is decreased in the vaccine that have been studied. And symptomatic disease is also reduced. Next slide. This is the comparison of the pandemic graph for the 6 regions of the WHO, and look at the top right, that is Europe. It is going up, up and up. And look at the bottom, Africa, blue one. It is going so high now, and there is no sign of its receding. It's on the upswing. Both Europe and Africa, as well as America, are the current focus of attention regions in the world. Next slide, please. Now we look at the pandemic graph of 6 countries in the slide, and next slide also has 6 countries. If we take the highest affected, United States of America, and it's going up. India, of course, is going down, but you never know. Brazil is going down. United Kingdom is going very much up, even higher than the highest in the past. Russian Federation, it has gone, just receded from the highest ever in the past. And Turkey is in the middle. It is neither at the bottom nor at the top. Next slide. Look at France. France is going on the swing where it can go higher than the highest in the past. Germany is just receding from the highest peak about 2 weeks back. Iran is going down. Spain is going again up. Argentina is on plateau, but Italy is on the upswing and approaching the peak that it had reached earlier. Next slide. This is the data, top countries with newly reported cases in the last 7 days, with the United States of America number 1, UK number 2, France number 3, Germany number 4, Russian Federation number 5, South Africa, Italy, Poland, and Spain and Turkey are the next 5. Next slide. These are the ranking of the countries in terms of deaths. United States of America, UK, France, Germany, Russian Federation, South Africa, Italy, Poland, Spain, and Turkey. This is the position of deaths in the last 24 hours. United States reported 45,092, while Russian Federation 7,924, Poland 2,944, and Germany 2,643 in the last 7 days. Next slide. This is the map of the world with sharing according to the cases reported in the last 7 days per 1 lakh population. And you see the darkest brown color. The entire Europe is darkest brown, as well as tip of Africa, which is South Africa, Mozambique. Next slide. This is the map of the world with deaths reported in the last 7 days per 1 lakh population with shading. The worst is dark blue and the best is light green. And you're seeing the darkest blue color is again in Europe. That means deaths in the per 1 lakh population are highest in Europe. Many countries you see very dark blue color. Next slide, please. This is the prevalence of variants of concern, alpha, beta, gamma, and delta in the last 60 days and historic detections data as on 14 December 2021. And what you're seeing, delta across the world and gamma mainly in South America, alpha mainly in South America, and beta mainly in Africa. Next slide, please. This is the presence of variant of concern, Omicron, as on 14 December 2021. Verified in 70 countries, under verification in 6 countries. Next slide. So, attention is the rarest and purest form of generosity, and I'm grateful for your generosity. Thank you for your attention.
Thank you so much, Dr. Jain, for that wonderful deliberation. Once again, we really appreciate your contributions. It will be an year of contribution from your side. It was 48 episode, which means we are just 4 weeks away from completing an year of that. Really appreciate your gesture. Definitely matter of concern. There is a wave of fear among people once again. And I, from the perspective of the way this virus is spreading, and I can see that from my area, my personal share, that there are few, like 3 or 4 containment zones which have come up in a radius of, I would say 4 kilometers from my place. So it is spreading that fast. Thank you so much for sharing that information, Dr. Jain. As of now, I do not see any quick question from the panelists or the audience, but then I will get to the panelists. Our speaker, the second speaker, Dr. Peush Bajpai, has also joined in. I can see him very much in mask. Very good evening, Dr. Bajpai. Can you hear us?
Yes, a very good evening to all. It was very enlightening, Dr. Jain, sir. Thank you for, this is something which we need to know really on a daily updates.
Yeah. So, Dr. Jain, would only request to please spare a few more minutes, and we will take up the deliberation and questions once the second presentation is also done. Hope that is fine. Thank you so much, Dr. Rajiv Jain, once again. And with that, I kindly invite Dr. Peush Bajpai Dr. Bajpai, appreciate your gesture of sparing your time this Saturday evening for our platform, AEUHD, which is a Delhi branch of Indian Association of Occupational Health. A quick introduction from my side. I am Dr. Pawan K. Gupta, Member Executive Committee of AUHD and Secretary, AEOH, Haryana branch. A very warm welcome once again. And yes, we were informed that you will be joining in around 7 p.m. So appreciate that. We are today here for 83rd webinar, just reiterating to the fact. Just when we began, we definitely announced that, just for your kind information, sharing it again. It's the 83rd webinar that we are doing, will be close to 2 years. We are continuously doing this, and we are really grateful to esteemed speakers and faculties like you who have continuously contributed for the betterment of society and for the enhancement of knowledge and their contribution. Really appreciate that. With that, I will give a quick introduction of Dr. Bajpai to all the esteemed panelists and attendees, and post that we'll hand over the platform to Dr. Bajpai for further deliberation. A quick introduction of Dr. Bajpai. Dr. Bajpai would be deliberating on the topic diagnosis of chronic lymphocytic leukemia. And he is HOD and consultant, medical hemato-oncologist, Manipal Hospital, Delhi. He's a senior consultant and HOD in the Department of Medical Oncology at Manipal Hospital, as I just mentioned. Cancer specialist with nearly 2 decades of clinical experience. Specialist in gynecology, breast malignancies, and hemato-oncology. Keen interest in molecular oncology, precision oncology, targeted therapies, immunotherapies, and the breast cancer management program at Manipal Hospital, Delhi. First prize as part of team in a case presentation at UK Breast Oncoplasty Masterclass 2016. First prize in All India quiz at Lymphoma Leukemia Meet at Mumbai, organized by European Society of Medical Oncology. Last but not the least, best poster in BTG, Hong Kong, prospective evaluation of musculoskeletal events in patients of CML on imatinib, mesylate, and correlation with electrolyte imbalances. Thank you so much, Dr. Bajpai, and those are wonderful achievements, and we really appreciate, and a lot of accolades for that, for your hard endeavors. Look forward to your deliberation. This platform is all yours.
Thank you, Dr. Pawan, and thanks for this opportunity. The topic of what I have been given today is diagnosis of CLL, and this basically becomes important as we talk about COVID as well, because this is one of the important and most common blood malignancies what we see. And most of us find it incidentally as an incidental lymphocytosis, and eventually we've diagnosed this patient as a CLL. So this would be the outline of my talk. I would be briefly covering on the disease, basically, the epidemiology of it, the pathogenesis and clinical course, the diagnosis, staging, and prognosis. And just summarizing, I would not delve into the treatment details very much. So just to define the disease, and this is a B lymphocyte, basically cellular disorder in the peripheral blood, bone marrow, and lymphoid organs. And B cells are morphologically mature. However, they are immunologically dysfunction and are unable to fight infections in this particular disease process. This is not just one disease. And with the advent of precision medicine, we can see that this has become heterogeneous because of the various mutations with the varied cells population. It may be very indolent and largely asymptomatic, and most of us do see at times when we discover them with this, we discover patients having incidental lymphocytosis, and these are the ones who actually have indolent disease most of the times. But then there is a spectrum of it on the other side, which is actually presenting with a very aggressive course, and patients do present with a very aggressive lymphomatous transformation or aggressive symptoms, what we call as B symptoms. And we all know that it is weight loss, sweating, and significant fever, hectic fevers happening. So this might present as a very aggressive disease pattern as well. And this is all again because of the cytokine storm which is brewing up. So blood smear and other diagnostic techniques, they all have evolved, which are able to now distinguish CLL from other conditions that can pose as CLL. CLL is one of the most common adult leukemia, and it is likewise in the Western world. What we see, the median age is around 60 plus. In the Western world, it is around 70 years in the Western world. But in India, what we find it is a decade earlier. Even in fact, at the age of 50 years, we start seeing a lot of patients having this disease. And in India, basically, for some reason, still undefined, it is slightly more aggressive than what we see in the Western world. There is more of the aggressiveness. There is more of the aggressive pattern. So talking about the incidence, well, this is some very crude figures what we have from India. Nearly a couple of thousand patients being diagnosed, and this is accounting for around 4.3% of all leukemias. So it's not very high in India, and this could be probably because of the reporting deficit. However, as you can see in the US, it is almost a third of all the leukemias. So this is what it is. And you can see that around 1,600 deaths. And if you look at the US, the figures are almost like half over there. So the deaths are lesser. So you can see that the incidence and the deaths, basically, it does reflect on the aggressiveness of disease in India. What is the pathogenesis? And if you can see that this is a disease of mature B cells, and when they are actually out of the germinal center, exposed to the various antigens, and there they get mature, they actually, the cells actually do not apoptosize, do not get apoptosized, probably because of the imbalance between the various genes. These mature B cells form a clone, and as we know that the B cell, the function of the B cell is to produce antibody, and this is one particular gene. As you can see, the IGHV, which if in case it's mutated, the B cell clone acts quite similar to the normal B cell, population. If the gene is unmutated, the disease pattern or the clone appears to be aggressive and has an adverse prognosis. There are other mutations which initiate or trigger the disease, and these are mainly 13q deletion, acquisition of chromosome 12. Some mutations which make the disease more aggressive are 17p deletion, and that is, as we all know, is the guardian of the genome. 17p, if it gets deleted, the whole disease process goes haywire. What are the risk factors? Well, this is one particular leukemia, and it's not very common with leukemias to have a family. You would find family history, but CLL is one particular disease pattern where you can find clustering in the family. So there could be like two brothers having CLL. So that could be important. I have a patient whose brother, both are in the age of 70, and both got one got incidentally diagnosed, and one became symptomatic and got diagnosed. So there is a clustering in this particular disease, leukemic set of disease. We have heard of it in cancers being genetic, but this is one particular disease which just definitely has clustering. Then of course there are exposure to certain chemicals, and this is quite common in acute leukemias. But again, this has been put forward that pesticide exposure, the radiation exposure does does give a spurt in this particular disease pattern. And then, as I just said, that what we saw the Western data, there is higher incidence. This could be probably because of that. The incidence not quite high in China and Japan. Age is very important. It's a disease of the elderly, as we just mentioned, more than 50 years, and males do have it more. Talking about the clinical course, the natural history of the disease, CLL is typically asymptomatic and indolent at diagnosis and in early stages. With the accumulation of mutations, as the disease progresses, the symptoms get aggressive, and CLL can progress to aggressive form that is resistant to chemotherapy. Refractory to CLL patients typically have short survival times, 9 to 12 months, and are more prone to infections. As you can see, that these patients have B cell immunoparesis. These B cells are not producing the proper antibody, so therefore there is some immunoparesis. You can see that there would be refractoriness to the chemotherapy drugs with the acquired mutations, and there is one aggressive form of it that's called the Richter's transformation, which is a transformation to a very aggressive lymphoma, which is quite akin to diffuse large B cell lymphoma. So that's a very aggressive form of disease. To talk briefly about Richter's transformation, and every physician should know this, that this is 5 to 10% of aggressive CLL patients. And when should we suspect it? When there are very hectic B symptoms. So prominent B symptoms, and I've already explained that night sweats, weight loss, and fever without infection are important. When we talk about B symptoms in a patient of CLL, there could be enlargement of lymph nodes. The lymph nodes could get painful, rapidly deteriorating clinical profile, or some extranodal deposits start happening. Some deposit near the eye, the scrotum, so CNS disease spread. So that is showing that it is then the aggressive format of it. How does it present? Well, 25 to 50% of the patients present without symptoms. So most of these times, these patients would actually have the indolent form of CLL, and the natural history would go, they would go beyond a decade without any problems, and most of them would go majorly without any treatment, almost a third of them. But some of them, 50% of them, might present with lymphadenopathy, organomegaly, and they would be predisposed to recurrent infections, anemia. Because of the marrow infiltration, basically there would be suppression of the hemoglobin, the platelet would fall, petechiae could be there, and then pallor would be there, and fatigue and night sweats would come, and abdominal discomfort because of the large nodes. So this is what the patients of CLL would experience. They would experience weight loss, they would experience enlarged lymph nodes, hectic fevers, and they would have undergone many infection disease profile tests, and they would have turned out to be negative. And of course, lymphadenopathy is one thing we should point out. Either it could be tuberculosis, which is a very big mimicker, or otherwise CLL should always be kept in mind when we look at the lymphocytes in the blood picture. So it all starts with looking at the blood picture of such a patient. It's basically when we find absolute lymphocyte count going above 5,000. And we'll then look into retrospectively into the clinical history, the physical examination, and the blood smear. So you get a call from your pathologist or your lab that, okay, doc, here is a patient, you send this peripheral smear, and you can see plenty of lymphocytes over there. And then what you should do is you should ask for a flow cytometry. Because the lymphocytes could be either because of the viral infection, the bacterial infections, the autoimmune diseases. But to prove that they are a clone, that is, they have turned into one particular clone, you have to actually look at the surface markers of that particular population and see whether they are arising from the same cell of origin. And therefore, flow cytometry helps. And if it is monoclonal, you establish CLL. There are certain factors which you look on the flow cytometry. So the diagnostic workup, of course, physical examination definitely is the key. The history is important. And you would find all these lymph nodes organomegaly. But it all, as I said, you might have an asymptomatic patient with a lymphocytosis. And there only you get a call from your pathologist that, doc, I'm getting smut cells. I'm getting a lot of lymphocytes. This is looking at some atypical cells, lymphocytes. So there, what should trigger is you can consider sending flow cytometry to see the surface markers of the cell. And there you can get, after this blood smear, you can send the peripheral blood. Peripheral blood is good enough. You need not do the bone marrow. Peripheral blood is good enough. And there on the right, you see these are the markers which are classically positive on the flow cytometry. Cluster of differentiation 5, 19, 20, and 23. These 4 subset of cluster of differentiation surface markers of the B cell. If you get it, then you can actually zero down on the diagnosis of CLL. Well, beyond the surface markers, as we know, these are all proteins on the membrane of the cell. There is something lying in the DNA, and that is what is essential to distinguish between the aggressivity of the disease pattern. So it is the IGHV mutation status, which is very important. As I said, that if the B cell has a mutated heavy chain portion, then these actually are better prognosis. The unmutated one actually behave awkwardly and have a poorer prognosis. This is one particular case scenario where you see that mutation is there and you have a better prognosis. But if you do not have a mutation, you have a poor prognosis. Most of the time it's reverse. So IGHV mutated have a better prognosis. TP53, on the other hand, as I mentioned, that TP53 is called the guardian of the genome. It corrects any abnormality, genomic abnormality, immediately triggers the corrective measures. So loss of this actually, TP53, can actually lead to a very aggressive CLL form. And then there are individual cytogenetic abnormalities as mentioned over here. And these, if present, basically, along with TP53 in particular 17p, they actually impede poor prognosis. This is what is NCCN guidelines, the guidelines to guide us where and how to manage, what are the diagnostic patterns which a clinician should look for his patients. And this is how we stage. And we can proudly say as Indians that Rai's staging system is by none other than Dr. Rai himself, and he's from Canada, and though from Canada, but a gentleman from our own state, Bihar. And here you can see that this is how stage 0 most of the times, as I said, lymphocytosis. This is the most common type what we see as physicians. And their indolent one, incidental detection, median life expectancy is 13 years. Intermediate, when you have lymphocytes and lymphadenopathy and organomegaly, then it is intermediate stage. But when you have anemia and thrombocytopenia, it is high stage, stage 3 or 4. So 2 things, anemia or thrombocytopenia would mandate a treatment initiation. Of course, anemia, other factors need to be ruled out like vitamin B12, iron deficiency. But if anemia is there and you have ruled out that iron levels are normal, B12 levels are normal, then you can probably discuss starting treatment about, treatment for CLL. This is what is the importance of staging. If you stage, you can actually get an idea that what and how long would be your median survival of your patient. So as you can see, in low risk and intermediate risk, your patient would definitely go beyond a decade. And in high risk population, these would be aggressive disease patterns. And I would not go into the detail again, but then these are all the mutations in CLL which we look for, and the prognostic values. I would not go into the detail again for this, but yes, as you can see, 17p is one of the high risk mutations which we again represent the TP53 mutation, which is a very high risk CLL. And TP53 either could be mutated, that is the P53 gene would be mutated, like there could be methylation, there could be deletion, or otherwise it could be deleted. That is, there could be a physical loss of the chromosome. So 17, the P part of the chromosome goes missing, and therefore you could have this. The impact, as you can see in the survival curves, if you have a TP53 wild type, that is, the gene is intact, you have a better survival in the red line. But if it is mutated, you can see that the survival, as you can see, the y-axis is representing the survival and the number of years in the x-axis. The survival falls, and therefore this is what is important to see when you diagnose your patient as CLL. So two things, IGHV mutation and TP53 mutation are very important to actually tell us that how the disease pattern would behave. So I would not go into the IGHV mutation again, as I just mentioned that if mutated, they do better as compared to unmutated. And this is one way you can actually look at the IPI score and say that, you know, how your patient would do. This is a accumulation of a lot of factors, not just the rise staging alone. So it does have now more precision medicine coming into play, where you have certain genes and this data becomes more precise. So this basically, as you can see, most of the times the CLL early stage and the intermediate stage usually do not get treated. But in advanced high risk stage, they should always be treated. So this is what is important. And this is the criteria for diagnosis, as I mentioned earlier, that one must always do the CBC and differential count, immunophenotyping of the peripheral blood lymphocytes, that is the flow cytometry. Then there is, of course, the importance of history, physical examination. And why you see the tests are on the top, but the history is in the second rung, because most of the times it's the lymphocytosis on the CBC which would trigger the looking at the entire thing actually. So then one should actually look at whether this patient would have lymphadenopathy or not. And then it all triggers down. So the indications of treatment, as I mentioned, thrombocytopenia is important, and then the anemia is very important. And sometimes if there is a massive spleen, of course, then you have to treat. If sometimes there are massive nodes, more than 10 centimeter, you have to treat. If there is very rapid progressive lymphocytosis, that is, it is doubling more than 50% over a short period, less than 6 months. So what we call as lymphocyte doubling count in a period less than 6 months. So then you have to treat. If there is autoimmune complications like thyroiditis, like autoimmune anemia, thrombocytopenia, ITP, then you have to consider giving corticosteroids. You need not treat such a patient. You can control with corticosteroids only. But if you have any organ infiltration like skin, kidney, lung, spine, then you have to treat. And or otherwise, if you have any B symptoms, of course, then you have to treat. So to summarize again, most of the times you will find on a blood work this sort of picture, and then that should trigger the whole gamut of physical examination, of course, the clinical history, the physical examination, the infection over past 1 year the patient had, and then of course, after seeing the lymphocytes, speaking to your pathologist, and then you can send for a flow cytometry for chronic lymphoma panel, chronic CLL panel, and you can you can then establish a clone, and then you can see that what sort of mutation this would have, TP53 or IGHV, and one can then get an idea. So this has been the treatment landscape, and it has rapidly, because of the thanks to precision medicine, there are now molecules, there are now oral tablets for treating a very, very aggressive disease pattern. Thank you.
Thank you so much, Dr. Bajpai, for that illustrative and informative deliberation. Isn't it comprehensible? Definitely, it is going to help us a lot. This is a platform of close to 3,000 industrial physicians across the country. I am sure you would have been given some background, just reiterating.
Yes.
All major Maharatna, Mini Ratna, Navratna, and all the major corporates of the country who are driving the Indian economy. These physicians, this is the backbone of the workforce to keep them healthy and on the move. Really thankful to all these physicians who keep contributing. I really appreciate your gesture for sharing your thoughts. There are some questions in my mind, but before that, I would definitely like to go to the panelists. And very unfortunate that Dr. Jain has to leave. Otherwise, we would have had some deliberation on Omicron and recent evolving situation about COVID as well. Somehow he had some engagement and he had just texted that he has to go. But then moving to immediately to Dr. Sanjay Rathitor for his comments and inputs, if any. Dr. Rathitor, if you are able to hear, please unmute yourself and share your thoughts.
Yeah, it was an excellent presentation, sir. Thank you very much.
Thank you, Dr. Sen.
Thank you, Dr. Rathitor. Dr. Behera, thank you so much for joining into this evening today. Really appreciate. Please. Dr. Behera, you can please unmute. Dr. Behera is from NTPC and he is one of the senior consultants and heads a division. Somehow, maybe he is not able to hear. I can see Dr. Kavita. If you're able to hear me, Dr. Kavita, please. Okay. Then a quick question. You mentioned something related to anemia, which is a major concern in India, 50% of the females. And there's a recent program also going on from in government, Anemia Mukt Bharat, AMB. I am sure they are taking huge steps in terms of to screen those people. How often have you diagnosed CLL from anemia perspective?
So anemia, whenever we see anemia and we see lymphocytosis, sir,
yeah,
and we see organomegaly or a lot of lymphadenopathy,
okay,
it's basically the lymphocytosis on the white blood cell count. So the WBC population should be high along with the anemia.
Mm-hmm.
And if we see the lymphocytosis, we send for flow cyte, we send for the peripheral smear.
Mm-hmm.
And what we do is, because it is anemia, we
Mm-hmm.
also do a Coombs testing.
Okay. Okay.
So we see whether direct Coombs test is positive, if it's isolated anemia, if there is no thrombocytopenia. So we do a Coombs testing, and when we find out that if it is like just the anemia because of CLN, and of course we do the B12 and the reticulocyte count and the iron profile, if all is good,
mm-hmm.
and it's all being attributed to Coombs test positive. So if we divide anemia, either it is Coombs test positive,
okay,
or Coombs test negative.
Okay.
So if it's Coombs test positive,
yeah,
then only IV methylprednisolone for 3 days, or the addition of rituximab for 4 weekly cycles
okay,
would do the job of solving or sorting that out. Of course, the micronutrient supplementation, folic acid and B12 and all that
yes,
can be given along with it, but that would sort the job for quite long. The patient of CLL would be treatment free for quite long.
okay.
But if the anemia is Coombs negative,
yeah,
and all other factors are ruled out,
mm-hmm.
but it is Coombs negative,
Mm-hmm.
and we do a bone marrow and we find that it is the CLL cells which are not letting the red blood cells grow.
Yeah.
then in that case, of course, it becomes important to treat.
Okay.
And there we go, by treatment, the very usual treatment. Yeah.
Thank you so much. The second and a quick one is there any demographical distribution as well that from in Indian demography, from a particular, I probably you would have shared, but I missed. But in India, as such, we have a very demography. Any particular region which is endemic, or where you see that they are more focus is needed when it comes to screening?
So it is basically a disease of urban population.
Okay.
Let me admit that I would say because of the access to the healthcare facility, this is a disease where you require what? You require a good peripheral smear reading.
Yeah.
You require what? You require flow cytometry to be done, which might not be possible in a lot of places. When we talk about, a lot of places now, things are getting better, and a peripheral smear can be read at various places. But you require that expertise to, trigger that alarm. Okay, here are a lot of lymphocytes, differential count reading. Now you have machines to do that, but then these machines are not everywhere.
Yes.
So that is important.
Okay.
So this is how we get to know wherever there is healthcare facility available with where you can do this sort of laboratory backup. There you would find that you would catch up CLL. And I don't think so there is much of a difference. Rather, I would say that there might be patients going unnoticed in a lot of our country, large part of our country.
Which is a major stage at which patient come to you? You would have, in your clinical experience, have experienced.
It is definitely, sir. It is definitely the early stage. Just incidentally detected lymphocytosis. We keep on getting various references from various other departments. Surgical patient who is planned for surgery, ekdam se lymphocytosis mil gaya. So they call up, and then gynecology, they call up before delivery. Not before delivery, that would be a pretty young age, but then it's usually some procedure. Some surgeons call me up, or somebody calls me up. They're bothered because of high blood count, and then lymphocytosis is there, which has gone unnoticed. So this is where a lot of them are incidentally detected, and incidentally means they are early stage.
Okay, great. And I think then we have a catch. And the last question from my side, and probably for the evening, any correlation lately, or you have seen any upsurge during COVID times? It has been a massive 2-year period now. Definitely you would have observed something within, if at all, any correlation or any upsurge during this phase, anything related to COVID situation?
For the COVID situation, I would say 3 things. One is not just CLL. A lot of cancer are getting delayed presentation. People are just sitting over it, and patients are not coming to us for the fear. They've been ignoring it for the past 1.5 years. So whatever the early stage, even we are seeing late breast cancers, late lung cancer, so a lot of other cancers, not only CLL. Yes, of course, sometimes we do see that some leukemias and cancers are, deteriorating. Now we are seeing some post-COVID vaccination, some patients attributing something to the thing to the COVID vaccination as well. Some abnormal skin reactions, patients on chemotherapy. Number 3 is that, of course, telemedicine has been a real boon for cancer patients as well. They need not come and can the regular cancer patients who are on treatment. But another important thing is the next generation sequencing, the precision medicine, which was oncology was a early, branch which actually utilized NGS and precision medicine. And thanks to that, there are a lot of oral medications in today's date that are benefiting our cancer patients. And just to give an example, for CLL, we have this ibrutinib and acalabrutinib, like drugs, which the patient can actually sit at home and, communicate over telemedicine and can have. So they need not come to the hospital to get injections like chemotherapy.
Perfect. Thank you so much. That was really precise and very helpful, I would say, Dr. Bajpai. Last question from Dr. Ghanshyam Dullera. He is from Schneider Electric from Mumbai. Dr. Dullera, you can unmute and ask your question, please. If you are able to hear me. He has sent me a text but I want if you can unmute and ask. Otherwise, I'll just read. What is the question? Question: what is the prognosis of CLL and life expectancy 5 years or more in proper treatment?
So with the proper treatment, life expectancy is excellent. I would say that with the sort of treatment which is now available, the lifespan is really increasing beyond 5 years any day. It's pretty easy to say. But however, we will find always a odd patient out, and there would be an odd scenario where the disease has been pretty aggressive. The treatment also has its own set of side effects, including high rates of infection, atypical infection like pneumocystis carni. So this is important. So it's not, it's something which we should, have an idea that we are dealing with the B cell. And it's all about the B cell where the antibodies are produced. So any treatment which are going to control the B cell are actually going to affect the immunity sometimes, though they would actually hit the backbones most of the times, but they could actually have some increased preponderance for certain rare infections, like they could hit the T cells for that matter. So most of the times the immunity does go up, but sometimes there could be a watch. We should keep a watch for atypical infection for patients on CLL. But otherwise, in today's date, most of the patients of CLL are having a good prognosis beyond 5 years with the current treatment available.
Absolutely perfect. I think that would have given a brilliant answer to Dr. Dulera. Thank you so much, Dr. Dulera, for taking up that question. And real gratitude and thanks to you, Dr. Bajpai, for sparing your time. I think that was an excellent discussion. This is all recorded. It will be available on the channels and all over social media platforms, as we call Lift. I mean, it's LinkedIn, Insta, Facebook, Twitter. We definitely keep publishing, but then there's YouTube channel. We can, anybody who has missed or whomsoever you want to circulate, they can definitely have a look at it. It was a thorough discussion and a very, very informative. And similar was our previous speaker also. He has shared wonderful insights related to the evolving situation of Omicron. I really appreciate gestures of both of our learned speakers for sparing their time this evening. Thank you so much. And we look forward to connecting with you once again, Dr. Bajpai and other panelists and esteemed attendees.
Thank you, Dr. Pawan.
A very good evening and thank you so much.
Thank you.